ठीक. So today we will be covering esotropia and mainly the concomitant esotropia in children. So why is it so important? Because
have not taken off yet, and if by API decided, and will take up a PE program in which shows that. But verbal children can this and in
Sir, I'm
congenital
muting
cancer.
all. You can unmute your mic. Dr. Love, you can unmute your mic now.
now why esotropia in children is important? Because it can be of various etiology and can be mostly vision threatening, but very rarely can be life threatening also. Esotropia in children and especially in infants is strongly embryogenic, so we need to treat that early. When you compare this with the intermittent exotropia, this is a much more serious condition because the chances of dense amblyopia and faster amblyopia is much higher in esotropia. Satisfying results if managed at correct time and aggressively. That is the most important thing. Why it is important? Because if we delay the management of esotropia, then we may not get the same result as we normally get with aggressive treatment. So common esotropia, what the commonest is the infantile esotropia syndrome. Then other types may be a nystagmus blockade syndrome, the Ciancia syndrome, accommodative and refractive and non-refractive, acute comitant esotropia, and Duane syndrome. Some of them are the differential diagnosis of infantile esotropia. So let us come to the most important and most common type of esotropia in children. That is the infantile esotropia. Incidence, as you can see here, I don't have the reference of this, but it is 1% of the normal newborns. It is 4 times more common in children with stormy neonatal history. As we had done in the squint evaluation yesterday, stormy neonatal history or perinatal history is very important for any child examination of the eye of the child, and can present as squint, and many times they have a pale optic disc, and it has a spectrum of anomalies apart from esotropia. We'll discuss risk factors. Sometimes it is genetic, then in premature children, low birth weight. Again, that comes in stormy perinatal period. Maternal smoking and alcohol abuse also has been shown to be associated with infantile esotropia. This slide is very important because again, infantile esotropia is a cluster of signs. It is not the only the squint. So please be careful about this slide. Every point is important here. The angle of the squint is large. It is quite large angle squint, and generally not much of refractive error. So what we get in accommodative esotropia is generally absent in infantile esotropia. Then onset is early, but very rarely at birth, but it's quite early onset first few months of life. And there is a apparent abduction deficit. So can someone tell why? You can just unmute your mic and tell. Why do we see abduction deficit in infantile esotropia? Because many of these children present have a phenomena called cross fixation. Like if there is esotropia, the right eye is fixing towards the left eye is fixing towards the right side, and that gives a false appearance, false impression that there is abduction deficit. So when we cover one of the eyes of the child, then you will see the movement has reappeared. So that is more due to cross fixation than actual abduction deficit. Latent nystagmus is a very common association of esotropia. How do we diagnose latent nystagmus? Suppose the child is having squint and no nystagmus. When we are doing cover test and when we cover one of the eyes of the child, then the nystagmus will appear. That's called latent nystagmus. There is another term called latent manifest nystagmus. Suppose the child is having nystagmus and we cover one of the eyes, then if the intensity of nystagmus increases, that is called latent manifest nystagmus. And sometimes these children also have a head posture along with the infantile esotropia. And another more very quite common association of infantile esotropia is inferior oblique overaction and dissociated vertical deviation. How do we assess the inferior oblique overaction? It's superior and nasal quadrant. When the eye is moving up significantly in the superior and nasal quadrant, then that will be a inferior oblique overaction. And if inferior oblique overaction is present, then generally it is associated with V phenomena. And same way, when superior oblique overaction is there, that may be associated with A phenomena. And another sign what we see in infantile esotropia is dissociated vertical deviation. What do we mean with dissociated vertical deviation? Like when we are doing the cover test and when you uncover, you will see that the covered eye has moved up and the recovery is a very slow downward and inward movement. That is called dissociate. Why is it dissociated? Because only one eye is moving up. That is why it is dissociated. And vertical deviation is vertical. It goes vertically. One eye goes vertically and there is no movement of the other eye. And what I told earlier, other feature is cross fixation. Then vertical incompetence, sometimes you will see that the vertical movement is less. V pattern definitely associated with inferior oblique overaction. And many of these children will have amblyopia. So we need to assess which is the unmaintained eye and do a amblyopia therapy aggressively before we go for surgery. So first we have to start with patching and then plan to go for surgery. Now, how do we diagnose, or what is the differential diagnosis of this? One can be a rare possibility, which is a early onset accommodative esotropia. So how will we differentiate that? The difference between the two is, one is the infantile esotropia is a very large angle esotropia. Accommodative may not be that large angle. That is one. Second is infantile esotropia may not be associated with high hyperopia. Most of the time it is not associated. But in early onset accommodative esotropia, the child may be having high hyperopia, and when you give the spectacles, the eyes become straight. So that is called infantile early onset accommodative esotropia. Second is pseudo esotropia. So I'm sure most of you would be aware of this. When the child is born, most of them will have some flattened nasal bridge and some telecanthus, which slowly improves as the child grows. So that gives an appearance of esotropia, which is not exactly a squint. And that can be, how do we differentiate that with infantile? The Hirschberg test, you will get a central pupillary torchlight reflex in both the eyes. So we are sure that it is a pseudoesotropia. Third is Duane syndrome. We have discussed Duane syndrome yesterday, so I'm sure most of you would be knowing. How do we now? This is confusing because even in, why is Duane syndrome confusing with infantile esotropia? Due to cross fixation, because infantile esotropia is having cross fixation, so we may get an impression that there is no lateral movement. So when we in Duane's, when we close one of the eye, that then also that lateral movement will not go, That is one point. And in medial movement, the eye will get retracted inwards. So that is how you differentiate a Duane's with infantile esotropia. Then fourth is lateral rectus paresis, again due to the cross fixation phenomena. So how do we again differentiate? Close one of the eye, infantile esotropia, the ocular movement will become normal, but not in lateral rectus paresis. And lateral rectus paresis is seen in children also many times after a episode of fever, viral fever, or something like that. So that generally improves by itself without any intervention. And there are some other functional deficits which is not very important at your level. I'll skip this. And then how do we treat these children? I hope the diagnosis part is clear. So next we come to treatment of of infantile esotropia. First, most important, the rule is that any esotropia, even with small hyperopia, we have to give full hyperopic correction. So infantile esotropia, if they are presenting with small hyperopia also, first you have to give them the spectacles and then reassess the squint angle with the spectacle on. Second, before we operate is treat amblyopia. We have to do patching for me first. It has to be initiated and done for few months, and then we go for surgery. It's not, yes, surgery is important. Early surgery is important in infantile esotropia, but never without initiating the patching therapy. If there is amblyopia, if there is unmaintained fixation of any one of the eye, then amblyopia therapy has to be started first, and then surgical alignment has to be done. Third is surgery. Again, there are various surgical options available that we'll discuss, either bimedial recession or medial rectus recession and lateral rectus resection of the same eye. Both can be done. And if it is associated with inferior oblique overaction, then we do inferior oblique recession as well. And inferior oblique recession, if done, has to be done in both eyes for good results. And follow-up care for amblyopia therapy. That is very important. The role of alternate occlusion, again, because sometimes when we are buying time for surgery and we are not sure about which eye is amblyopic, and if we feel that both eye are equally fixing equally, then we can give alternate eye occlusion. That is more because of the cross fixation, because a constant state of cross fixation may lead to fibrosis of the medial rectus if it has not been broken regularly, because that is always in the contracted state. So till we do the surgery, we can give alternate eye patching in these children. But the result of the same does not, the alternate eye patching doesn't help with the post-operative results if there is no amblyopia. So why we are doing patching is just to keep the eyes mobile before the surgery if the child is not amblyopic. Now, the important part of the management is the surgery. Again, early alignment is desirable, and the consensus is that it should not be beyond 2 years of age, as early as possible, but not beyond 2 years of age for infantile esotropia. Then the amblyopia that may set in will be very dense and difficult to treat later on. And most important, apart from the amblyopia, the fusion and stereopsis will get lost forever if we don't operate early in these children. And the common surgery in this is bimedial recession. So both the medial rectors are weakened so that the eyes become parallel. And what is the desirable result of the surgery? Either a straight or a microtropia up to maybe esotropia of maybe 4 to 6 or maximum up to 8 diopters. 10 to 12 also is acceptable, but more than 15 prism diopters of residual esotropia may require another surgery, and which will be maybe 6 months after the first surgery. Frequent follow-up for amblyopia is required, and sometimes if they have a DVD and may develop DVD later on, then we need to operate again, and the surgery that is done, and there is a surgery, inferior oblique weakening procedure are different categories. One is recession, one is anterior transposition. So if there is inferior oblique overaction along with DVD, then we do anterior transposition. Now let's come to the other uncommon types. One is nystagmus blockade syndrome. Suppose a child is having nystagmus and the nystagmus becomes less intense when the child is converging. So that may lead to esotropia just because the child is putting too much of effort for the dampening of the nystagmus. So, and this can be associated along with phase turn also, because if the sometimes the null point may be convergence and a phase turn, that may be the null point of the nystagmus, so can be associated with phase turn also. And sometimes they may require bimedial recession for the nystagmus dampening. Now the next common one after infantile esotropia, the most common is the refractive accommodative esotropia. Now it's very important that we understand the difference between infantile esotropia and accommodative esotropia. The most important difference is the age of onset. Infantile esotropia will start within the first few months of life, and accommodative esotropia generally starts by 2 to 3 years of age. And it initially it starts with an intermittent near angle, and near angle more than the distance. Like when the child is doing some near work, then the squint starts appearing, and almost invariably associated with high hyperopia. And once you give full correction, the squint disappears. And in these children also, amblyopia is common, but it is a better prognosis as esotropia. Because why? Because the first 2 years of life, the child is seeing straight. So by that time, he has developed a good stereopsis and binocular vision. And when the accommodative esotropia occurs, it occurs for a limited period of time, because generally infantile esotropia tend to get more neglected than accommodative esotropia because of the acute onset of the symptoms. So a growing child and suddenly the eyes start deviating, the parents get panicky and they bring the child for a checkup. So that is why also the prognosis is good. Now, how do we manage it? Good alignment, equal vision in both eyes, which will be done, good alignment will be done with spectacles. Equal vision in both eyes will be done with spectacles and patching. Good binocular vision anyway will achieve it with alignment of the eye if it is done immediately after onset of the problem. So definitely full cycloplegic correction in all esotropias. That is the rule. So don't deviate from there. Any esotropia, whatever cycloplegic value you get, full correction has to be given. Amblyopia has to be dealt with. Is there any role of surgery? Sometimes yes, because sometimes some of these children have a partially accommodative esotropia. What do we mean by partially accommodative? That when we correct, when we give the full correction to the child, full hyperopic correction, then the squint improves, but it doesn't become ortho. So in that case, the surgery has to be done only for the residual squint over the spectacles, not for the squint without the spectacles. And parents have to be explained clearly that we are correcting only the squint that is appearing with the spectacles on. Otherwise, they will be very unhappy after surgery when they see the residual squint without the spectacles. So that counseling is very important when we are doing a surgery for a partially accommodative esotropia. Now, a non-refractive accommodative esotropia. This, in common terms, what we have discussed yesterday is the high AC by A ratio. Again, in these children, what happens? There is esotropia, there is hyperopia, and the distance of for the squint for distance is different from the squint for near. Suppose, for example, distance squint is measuring at 30 prism diopters, the near will be 45. So when we give the full distance correction, then that gets ortho for distance, but near 15 remains. So in these children, it is always very, very important to give a bifocal executive or debifocal, bisecting the pupil, so that even slight for near vision, the gaze is generally downwards. So whenever if it is bisecting the pupil, then always the child will see through the lower segment of the spectacle, and then that time that residual 15 will also get corrected. And bifocal addition is always +3 over the distance. And what do we do later? We keep on following the child as the child grows older, and slowly where that high AC by A ratio component may go, and distance and near may start becoming the same, and then gradually the power near power addition is reduced and the child is weaned off the bifocals. So again, management is full correction, amblyopia treatment, if any, bifocal, I've discussed already. Bifocal specification must be emphasized. Many times the opticians themselves don't know what we have written. They will they will make either a normal bifocal or they may call from the shop itself that as to what is to be done. So it is important that in the glass prescription itself, we draw the bifocal line, that it has to be at this level. And partially accommodative, we have already discussed. Then comes acute comitant esotropia. Sometimes it is also called acquired esotropia, that a child who is absolutely normal and no refractive error, no component of accommodative part, and develops esotropia. Ocular motility is full. Any abnormal presentation like that, even for example, uniocular nystagmus, these kind of situations, you should always suspect something wrong in the brain, especially the comitant sudden acute onset squint, and sometimes squint which you cannot explain with anything. In those cases, neuroimaging has to be done, and they may be associated with hydrocephalus or posterior fossa tumors, and surgery may be required for that. Now, if you remember the first slide, what I had told, why is esotropia important? Because it may be vision threatening and occasionally life threatening also. This is the situation in which esotropia becomes life threatening. And sometimes, rarely, it may be associated with retinoblastoma also. So again, that also is a life threatening situation. So any child with esotropia has to be taken seriously. Thank you so much. Now we'll go to